It is my sincere pleasure to welcome Duncan Wilcox to our Frank Hinman Jr. VP. He is an incredible colleague and friend, and we've already been having a great time. He's been schooling us in golf. Yesterday we were at Topgolf. He comes now from the University of Colorado, where he's the surgeon-in-chief. But prior to that, he trained at the University of London, and of course we associate that with Great Ormond Street. He was there for a number of years and also did a research fellowship at the University of Buffalo. His current research interests are in anorectal malformations and other complex reconstruction, and he really is a leader in our field, and we're looking forward to learning from him today with the residents and also this afternoon when we exchange research ideas, and we're very excited to have him here today. Thank you, Duncan.
Well, thank you very much. Obviously, it's a great honor to be the Frank Hinman visiting professor. You know, I think we all know Frank Hinman from his book and his syndromes. And then I find out he was NIH funded for almost his entire career. He published over 250 publications, which makes us all a little embarrassed by our own set of publications. But not only that, he was a painter, and I understand that he got things published in magazines, and I think he was Yachtsman of the Year, so clearly a Renaissance man. So thank you very much for inviting me today. So what I hope to do today is to describe about posterior urethral valves and the early management of it, then talk really about how it affects renal and bladder function, and discuss how we can improve or maintain bladder function, and by doing that help to improve renal function. I'm going to talk about some of the treatment options that we have for managing the bladder, and then at the end talk about some future possibilities that we have to improve how we manage the bladder in particular. So I suspect almost all of you are aware of the clinical problem. Posterior urethral valves only affects boys. It happens about 1 in 5,000 live male births. And it has a significant impact, even though it's not very common, and that it's about 10% of all prenatal uropathies. So it's a common problem that we see, and represents still today about 1/3 of all end-stage renal disease in children. What's interesting is that a lot of these patients are incontinent of urine, and as I'll show, the relationship between incontinence and renal outcome is quite marked. So there are 3 types of posterior urethral valves that are described, and the classification really hasn't changed very much. Type 1, which I think is the most common, is what you see here. It comes off the veru. Type 2 comes off the bulb, and type 3 comes off the veru and goes up onto the anterior urethra. There is some degree of debate about these classification, because if you look in before instrumenting the urethra, what you actually see is not a valve, but you see an obstructive membrane with a single pinpoint hole, which suggests that what we actually see in valves is the result of the placement of the catheter prior to doing the cystoscopy. So far, there have been familial studies of patients with valves, but I'm not aware of any actual genetic cause so far. But I suspect with all the whole genome, we'll find it soon. So the problem is increasingly diagnosed prenatally. So about 80% of patients are diagnosed prenatally now. And what you see on your left is the spine to the right, and then this sort of classic large bladder with a hypertrophy bladder neck, and the posterior urethra, which is dilated. And you can compare that to what you see in the VCUG, which is pretty much exactly the same thing. One of the things I think you should notice here is that the posterior urethra is very dilated, and that's important when you come to placing the catheter. So typically these patients will have bilateral hydronephrosis. There have been some reports of unilateral hydronephrosis in valves, but that's very rare. And the important thing here, especially for your boards, is that if you see a boy, and you could argue a girl, with bilateral hydronephrosis, you have to do a VCUG. You need to exclude this diagnosis. The timing of the VCUG is debatable. Some people say that you have to do it really early on. My belief is that this is something that can wait, because most of these patients will have electrolyte abnormalities, and it's worth fixing that before you start to investigate it. So I don't think this is an urgent factor. So the problem is that a lot of parents consider posterior urethral valves to be a small valve leaflet, and that once this is repaired, everything else will be fixed. That is far, unfortunately, from the truth. This is a field defect, as you see from this post-mortem study, in which the kidneys, the bladder, and the urethra are all involved. And our role here is to really maximize renal function, and the only way we can do that is by improving the bladder and making sure the bladder doesn't cause further problems. And so our role is to reduce urinary tract infections and make sure the bladder pressure is acceptable, and that the patient is emptying the bladder on a regular basis, and hope in the future we can create continence. So the early management is to place a catheter, and most of the time that's done urethral rather than through a suprapubic catheter, although some studies have used a suprapubic catheter. Placing a catheter can be sometimes quite difficult, because the catheter goes into the posterior urethra, you get urine back, you think you're in the bladder, but you're not. And so it's really important to put the catheter all the way in. Sometimes even that, it curls up in the posterior urethra. So be cautious about placing the catheter. Sometimes a coude catheter will help in this situation, and I find sometimes a slightly larger catheter will help. We rely on our neonatal and nephrology colleagues to manage the fluid and electrolyte management, especially because they'll often have a post-obstruction diuresis, so you have to worry about that. Remember that the early creatinine you see is not the creatinine of the fetus, but the creatinine of the mother. So if you see a high creatinine, think about the mother's renal function, not the baby's renal function. And it's really about how quickly the renal function improves, which gives you an idea of prognosis. After that, it's necessary to resect the valves. Once again, this is not an urgent thing. Often these these neonates are going to be in the NICU for a while afterwards because of stabilizing the renal function. So this is certainly something that can be done during the week. In terms of the VCUG, there is a lot of opinion about whether the catheter should be in or catheter out when doing a VCUG. I'm not convinced it really makes any difference. I don't see anyone strongly disagreeing in the front row. So I think the advantage of leaving it in is that the radiologist doesn't have to put it back, or you're not called to put it back, which is the most frequent. There is some debate about doing a circumcision in these babies, and more recently the Toronto group have shown reasonably convincingly that a circumcision does help with urinary tract infections. However, the number needed to treat is greater than 10, so my approach to this is if the family are thinking about a circumcision, I strongly recommend they do it. If they're adamantly opposed to it, I don't push them into it, but tell them about the potential advantages of doing a circumcision. Because almost all of these patients will have the psychourethric reflux, I tend to put them on prophylactic antibiotics and then follow them up closely. I personally think that all of these patients should be referred to nephrology, however good the renal function appears, and then nephrology have the option to not follow them up if they feel they don't need to. So sometimes when you put the catheter in, the urine drains, but you don't see an improvement or as good an improvement as you'd like in the hydronephrosis or in the renal function. And then the question is what to do. And I think what we should do most of the time is be patient. Sometimes, after 48 hours, you're not going to see a lot of improvement. Even after 72 hours, you may not see a lot of improvement. And I think the reason for that is when you put the catheter in, the detrusor muscle contracts because it's now empty, and that can restrict the UVJ. At some point, you have to say that draining the bladder isn't doing the trick, and then you have two options. You can either do a nephrostomy tube to see if that helps, or you can do a urostomy and some sort of ureterostomy, and that is increasingly becoming popular, especially in Canada. So there are a number of predictors of chronic kidney disease. Hypodysplasia is a term which I hadn't fully heard of, but it relates to three things. One is hydronephrosis, echogenic kidneys, and echogenic renal cysts. We remember postnatally a lot of these neonates and infants will have reasonably echogenic kidneys. That's normal, and it improves with time. There have been a huge push to try and see fetal urine predictors of renal function. I think none of them have been particularly good. I don't think we routinely use them, although the group from Chicago now have a proteomics panel, which seems to be more encouraging, so we'll see. Postnatally, obviously, if the ultrasound looks terrible, that's a concern. Oh, and I forgot to mention, obviously, oligohydramnios or anhydramnios is a very significant predictor. If the nadir serum creatinine, and that's usually about a week to 10 days, gets below 0.4, actually they have a really good chance of not having end-stage renal disease in their life. If it's certainly above 1, the chances go up quite significantly, as we'll see later. And bladder dysfunction is also related to renal function, and we'll talk more about that. So this was a study done out of Great Ormond Street, which looked at the nadir creatinine below 8 or above 8, and at 10 years, about a quarter of them had gone into chronic renal failure, and by 20 years, nearly half of these patients had gone into chronic renal failure. And the reason why that's important is I think as pediatric urologists, we tend to see our time very much until 18, and then after 18, it's other people's problems. And I think it's really important that these patients get followed constantly. I think we always used to say that they should get followed for life. More recently, Dan Wood has presented some work which suggests there are a few select patients who probably can discharge if they're completely continent of urine, emptying their bladder, and have normal renal function once they've been through puberty. But that's a relatively small number. So many, many years ago, Craig Peters described 3 types of bladder dysfunction, roughly divided into thirds. That was instability, hypertonia, and myogenic failure. And it appears to be a transition. So patients will often transition through into myogenic failure at the end. And this is probably related to the pressure. The increased pressure within the bladder leads to hypoxia, which leads to fibrosis, which leads in the end to myogenic failure. There is a number of studies which have shown a relationship between incontinence and renal function. This is a study, again out of London, which showed that if you had renal continence, your chances of having renal failure are very low, and if you had no continence after 5, your chances were pretty poor at having normal renal function. And that's been shown time and time again. This is a more recent study out of Madrid, which shows exactly the same thing. If you look at end-stage renal disease, if you have a normal bladder function, only less than a quarter will develop end-stage renal disease, but if you have abnormal bladder function, nearly half will. And I suspect this is what you're born with. I suspect a lot of this is the fact that it's a field defect, that you have bad kidneys and bladders because the whole urinary tract has not developed normally. But obviously the only thing we can improve is bladder function, so that's what we have to concentrate on. So how can we intervene? Well, the holy grail was to do prenatal intervention, and coming from San Francisco, you know an awful lot about that, I hope. I think Mike Harrison was one of the first people to describe this, and certainly one of the first people to do it. Sadly, it hasn't been the panacea that we all wished it was, but we'll talk more about that. And then I'll go on to talk about some of the ways we can manage the bladder and the bladder neck postnatally, and then end on some hopeful future directions. So coming back to fetal diagnosis, there are a few components that you see. Firstly, it has to be a male bladder, male patient. It has to have bilateral hydronephrosis. It usually has echogenic kidneys, and if you wait, it will develop oligohydramnios. As I've mentioned, urine markers are not particularly helpful. The issue here is that patients with high-grade reflux may also have a similar picture, and patients with pruned belly or megacystis may also have a similar picture. And obviously, they won't benefit from intervention. And so it's important to try and differentiate those. And MRI scans now, I think, are being very helpful in that regard. So this is a study looking at a diagnosis of megacystis, and unfortunately this is a time when megacystis was diagnosed really by saying it looks big, rather than any objective measures. But having a big bladder early in pregnancy at the 20-week scan is really very bad news. This is a European study, but so maybe the termination rate would be a little less here in the United States. But as you can see, if you look at those 37 fetuses, only 8 of them left the neonatal intensive care unit. So that is really what led to people discussing intervention. And there are, I think, a few rules about who we should intervene on. Firstly, it has to have bladder outlet obstruction, because if it doesn't have that, then the shunt or whatever you're doing won't help. I mean, ideally, it should be before renal damage. The problem with this is that the glomeruli start producing urine at about week 8, and it's pretty unlikely that you're going to diagnose this much before 20 weeks, because most of them will not have their antenatal anatomic scan much before 20 weeks. And you really want to try and be able to fix some of this renal impairment, and you want to do it before they get lung problems, because the major cause of death in these patient groups is pulmonary hyperplasia. And that's because the lungs rely on amniotic fluid to help develop. And after about 16 weeks, almost all of the amniotic fluid is urine. And so this is one study that looked at patients who've been shunted. There's been a more recent meta-analysis which has shown essentially the same, which was that if you have no shunt and poor prognosis, your chances of surviving in infancy are very poor indeed. If you have good prognosis, then about half of those patients will survive. On the other hand, if you shunt, then some of the poor prognosis patients, about a third, will survive. Almost none of them will get away without having end-stage renal disease early in life, though. And the good prognosis group, more of them, nearly all of them, survived with shunting. And that's something I'll come back to. So this was a study that was hoping to show to us what to do. This was a multi-center, multi-country randomized trial that randomized patients in the poor prognosis group to a shunt or no shunt. And unfortunately, it had to be closed because they just couldn't recruit patients. And I think that's because when patients were told of the likely outcome if they didn't shunt, none of them wanted to be randomized. So I think the study was open for about 3 years before it was closed. And it tends to hint that shunting can help these patients. So in the shunted group, well, half of them survived, but only 2 of them had normal renal function. And fetal demise on shunting is not uncommon. and the reason for that is, you're talking about a 20-week fetus, probably weighs 500 grams, 600 grams, and you're putting quite a large needle into the bladder. And the problems with the shunts that have coils on them, as you see in this one, is that they come out. So in this trial, most of these patients had 2 or 3 shunts before the baby was born, and every time you do that, you cause an increased risk for early premature labor or demise. There are some types of newly developed shunts which look a bit like the vascular shunts with the slightly metal ring, which when they expand, they grow into the bladder and they tend to dislodge less often. And so the German group are using that with more success. One of the problems with shunting is that when we see well, 2 problems. One is we've concentrated on those patients who have poor prognosis, and maybe the horse is out of the barn at that point, and maybe we should be moving it towards those patients who have reasonable or good prognosis in the hope that we can maintain their renal function as it is. The other problem is that a lot of renal maturation has occurred by 20 weeks when we see these patients, and so ideally we should move it forward, but once again that is unlikely because of when we diagnose this and the technical difficulties of doing it at that stage. One of the things that I think for those of you who are involved in prenatal counselling we need to be cognizant of is, the families need to be aware not only of the survival chances and the end-stage renal chances, but also what living with a baby with end-stage renal disease is like in infancy. Essentially one of the parents is going to have to give up work to live in the NICU. Unfortunately, we've been really good at selling ourselves. Everyone thinks that medicine can cure everything nowadays. But managing a patient with dialysis in the first year of life is extraordinarily difficult for the family. And certainly my experience, and I'd be interested to hear others, it's pretty rare for a family to stick together once they've been through this. I'm embarrassed to say, but usually the man leaves. So people have tried fetal cystoscopy. The group in Miami did a lot of this. Our fetal team did this in Denver for a period of time. The rationale behind this is that if you resect the valves, then the bladder can cycle and you can improve bladder dynamics going on. There are a couple of things about this. To do it, you don't go through the urethra, which for a long while I thought they were doing. You go antenatally through the bladder and down. Having watched this on a few occasions, and I apologize if people in this room have done this, I never convincingly saw the bladder, neck, or the urethra. And interestingly, the incidence of urethral atresia in these studies was much greater than we see in autopsy studies. So I'm not convinced that they weren't creating that. This has gone out of favor. I don't think anyone's doing this nowadays. So postnatally, looking at bladder function, there have been a number of nice studies. This is a Swedish study in which they looked at urodynamics prior to resecting the valves. And they essentially showed what Peters showed a long while ago, was that to begin with you have a large capacity bladder that has instability. And then by about a year of age, what's happened is that you continue to get instability, but the functional capacity goes down. And then by 5 years, and this is what we did, you see them divided up into 3 groups, roughly a third in each group. And the first is a normal. These patients seem to be lucky. They tend to have a normal bladder. And what happens is when you look at video urodynamics, you see they have this sort of classic monophasic emptying profile. They empty extremely well, and their bladder neck relaxes and allows funneling so that the urine comes out easily. Obviously, this is the people in the good prognostic group. And then you have the so-called compensated group. And they void with very high pressure. They have inability to relax their sphincter mechanism and their bladder neck. But because they void with such high pressures and have multiple voids, they'll empty. And this is the group, and I'll go on to this, that we should be managing. But unfortunately, the families see a normal child. This is a child who's able to void, tends to be without urinary tract infections, and tends to be continent. And so you're telling a family that they think has a normal baby, that they need to do something about it. And that's difficult. And then the last is the so-called myogenic failure. These are the patients who've been voiding under high pressure for a long period of time, and eventually the bladder just gives up, and you have this large capacity bladder, which has relatively low pressures. And this actually, for those people in chronic renal failure, can be an advantage because you don't need to do an augment on these people, so you can actually wait a bit and not do augments. So what are the treatment options? I think vesicostomy is an option in these patients, and I'll talk a bit more about that. Increasingly, the Toronto group are talking about doing bilateral ureterostomies and taking the bladder right out of this. And we'll see, they're being very aggressive. They're doing it in the first week of life, and they're reporting early good renal outcomes, but very early, so we'll see. Clean intermittent catheterization certainly is an option. I find this quite difficult to get families to do, and there are two reasons for that. One, these boys have a normal sensate urethra, so it's difficult to get them to catheterize. And two, catheterizing is not that easy. There are a number of pharmacological agents that have been used, and I'll talk more about that. And then in the compensated group, there is an argument to be made for incising the bladder neck. So this is some work that I actually did looking at vesicostomies versus ablation. And I don't want to give the opinion that I think everything can be solved by a vesicostomy after yesterday's discussion. But this was actually a cohort study in which my predecessor didn't have the instruments to do ablations, so did vesicostomies on everyone. And then I did ablations on everyone, and we looked at these patients with their 5-year follow-up. And to me, it was actually quite interesting because I'd been led to believe that defunctioning the bladder would lead to terrible bladder outcomes. And that wasn't the case. In fact, these groups did pretty much identically. And what I took away from this was that if you're having problems with a child, vesicostomy is an option that you can use. I mean, I still ablate them primarily, but I think you can use vesicostomy. And I think it puts certainly a lot of debate about and doubt about whether bladder cycling is something that's as important as I think we're all led to believe. Some people have tried hard with clean intermittent catheterization, and what they showed was that you could decrease instability by that. Actually, the renal function didn't seem to be much different. And this may well be related to many of these boys would then be put on oxybutynin, which I think helps reduce the pressure, helps with the instability, and helps with later fibrosis. Unfortunately, it's difficult to give them oxybutynin without clean intermittent catheterization because then they just won't empty very well for you. A lot of people have studied tamsulosin, and in fact there was a very recent meta-analysis looking at this. And really, unfortunately, tamsulosin didn't really change anything. And actually, that doesn't surprise me when I think about it, because the bladder neck and the sphincter are not normal. They're fibrotic. It's not surprising to me that medication didn't help relax the sphincter. And I mean, I think we can try it, but I think there's really no evidence to suggest this helps now. People have also tried botulinum toxin with actually pretty similar results. And I think for the same reason, if you don't have a good muscle there, it's unlikely that Botox will help significantly. And finally, bladder neck incisions. And what's interesting about this is, medicine, everything comes around in a circle. Bladder neck incisions were very popular in the last decade. And if you go back to Hendron's original description of resecting the valves, he resected the valves and went up and made a big incision in the bladder neck at the same time. So we just keep going round and round in circles. But what this study showed, and a recent review article showed, was that bladder neck incisions can make a difference with overactivity. Overactivity tends to go down when you incise the bladder, emptying pressures go down, but actually the need to intervene didn't really change. So it's unfortunately not as helpful as we thought, but you know, I certainly think in patients in which you see a very high bladder neck and a very high pressures and polyphasic emptying, that it's probably worth offering still. This is an interesting thought, and I think many people are now doing this. This originally described out of Columbus, which was that patients with posterior urethral valves tend to have polyuria, and the reason why this is important at night is during the day the children just void often, or are incontinent and void often, but at night, of course, they tend to go along with a reasonably high pressure for most of the night, and so this can lead to problems with chronic kidney disease. And so patients are then placed with a catheter. Often you have to do a mitrophenol in these patients because they don't tolerate urethral overnight catheterizing. But this did show significant improvement in hydronephrosis and urinary tract infections. The other thing that isn't mentioned in this paper, which from my experience is really beneficial, is that you solve the bedwetting, which is a big issue because they're producing 2.5, 3 liters of urine overnight. So that's difficult to manage. So as I said, bladder augmentation isn't as necessary or frequent a problem in these patients as you think, because the bladder tends to evolve into this large capacity, low pressure system. And so you don't often have to do it. But in studies in which patients have gone on to needing renal transplantation, the outcomes in patients who've been augmented and those who have not are actually very similar. The only thing that I would say is that don't augment prior to getting urine into the bladder. That is a problem. I don't know what your experience is. There was a time when people wanted the bladder fixed before they transplanted into it, and I think that if you're not producing urine and you have an anuric augment, that's a real problem to manage. So after all of that, what do I do? Well, what I tend to do is we put a catheter in, and I leave it until its creatinine is stable, and then I organize the VCUG. So I tend to do the VCUG during the week, not at weekends, certainly not at nights. I resect the valves, and then I offer a circumcision. I then recheck at about 3 months, and I get an ultrasound, and if the ultrasound hasn't had a dramatic improvement, I'll scope them again to see, because sometimes you'll see valve leaflets that have remained that you can improve, and so I think that's important. I rarely do CIC unless they have large residuals. If I do CIC, I'll put them on oxybutynin. I do ultrasound scans every 3 months in the first year of life. I think we made that point yesterday. I don't know how valuable that is, but I certainly think keeping an eye on them. I refer them all to nephrology, and I get nephrology to discharge them. And in fact, we now have a joint clinic that we run monthly with our nephrology colleagues, which has been really good for patients and really educational to me. So it's been a good clinic. I do a renal scan at 3 months. This is really just to have a baseline so that in future if you see changes. And what sometimes you'll see is one kidney is clearly acted as a pop-off valve, and the other kidney has been protected, which did seem for a long while to be an indicator of good prognosis, but actually I suspect now we've shown that it really doesn't make much difference. It's just that one kidney is protected and one kidney is more normal. I do urodynamics at 1 year and 5 years, really to look to see if it's this compensated. We've actually just looked at our data, and we're probably going to go away from doing it at 1 year because it doesn't seem to change what we do very much. I do discuss bladder neck therapy. Usually now that would either be Botox or incision, and I'm pushing more towards incision. But I have to say I don't get many takers. Most families don't want to do this. And certainly if they have polyuria, I will recommend overnight drainage, which means a mitropanoff. And I'll continue to see them all the way through puberty. So what does the future hold for posterior urethral valve patients? So I think that there are two therapies that are currently ongoing. That there was a recent study showing that people are trying to shunt these patients in the first trimester, and to shunt those patients without oligohydramnios, the idea being that you get at it before the renal function has completely disappeared. We'll see. I think that is a study that should really only be done in really good fetal care centres, such as here, and there aren't that many of them, so that we actually can see if it works, rather than let everyone have a go at it. As I mentioned earlier, the Toronto group are getting very aggressive about early ureterostomy, and we'll see how that works out. I'm less convinced about that because, at 9 months, those kidneys and bladders have been obstructed for 7 months already. So I really think diving in week 1 is not really necessary, but we'll see. And then I want to talk a little bit about some potential work that we've been doing in our lab looking at bladder muscle therapy. So what we showed a number of years ago was that if you partially obstruct a mouse model, and the reason we use a mouse model is because they continue to have some renal development postnatally, that you get hypoxia in the bladder, and we showed this through VEGF expression. And so what we do in 5 to 8 week old male mice, we create partial bladder outlet obstruction, and we do that by putting in one French tube and then suture ligating it, and then taking the tube out. And then we follow these patients, and then at 2 weeks, we investigated them. And what you can see here is that in the patients with in the mice with partial bladder outlet obstruction, you see a significant increase in collagen, which is in blue, and the sort of detrusor looks much more disorganized. And that sort of mimics what you'll see in posterior urethral valves. If you look on the left-hand side of your screen, this is the HIF, our hypoxia-inducible factor. And when there's oxygen present, HIF is made and degraded, and so you don't get high levels of HIF produced. However, in places where you have ischemia, HIF is produced, and this leads to a stimulation of a number of HIF target genes. And I'll talk about them, but obviously VEGF, you get some sort of cell proliferation, and you get this epithelial to mesenchymal transformation. And what that happens is you get fibroblasts and myofibroblasts formed, which leads to fibrosis and obviously impairment of muscle activity. You also get stimulation, and I think I show it here, yes, stimulation of smooth muscle actin and vimectin, which leads to detrusor expansion or hypertrophy. So if you look at the histology in the upper right, what you see is that in our outlet obstruction, HIF increases, which supports our hypothesis that HIF is a factor. And then E-cadherin, which is a urothelial marker, goes away, or you get less of it. And that indicates that there's been this epithelial to mesenchymal transformation. So from this study, we summarized that partial bladder outlet obstruction leads to ischemia, which leads to hypoxia-inducible factor activation, which can lead through EMT to fibrosis and detrusor hyperactivity, and therefore bladder dysfunction. It can also lead through the inflammatory pathway, which we didn't actually study, to further expand this. So our next study was to try and block this HIF pathway, and we did this by using 17-DMAG, which is a chemotherapeutic agent, which blocks heat shock protein 19, which is similar for the HIF pathway. So by blocking this, we blocked HIF, and the hope was that that would help us. So if you look at the histology, what you find is that by giving DMAG as opposed to giving a placebo, you see less HIF, which is not unexpected because DMAG inhibits HIF. But what was nice to see, if you look in the pretty pictures below, is that in the middle you see the impact on collagen deposition after 2 weeks in these bladders, and when you have HIF blocked, you see a partial reduction in collagen production, suggesting some improvement. And then we looked at detrusor contractility in muscle strips. And for those of you who are not familiar with it, EFS is doing it through the nerves, and then Myostat was looking at collagen activation, so cholinergic activation. And what you see is you see a partial improvement. So the blue line is the control, and then the green line is the one with DMAG. And you see that contractility improves with DMAG compared to the placebo. And in the bottom, you look at basal activity, and that's a sort of indication of instability. And you see, once again, you see some improvement. Not complete reversal, but some improvement. And this is a study that we looked at urodynamics in these mice. Now Higuchi, who's the postdoc who works in our lab, is clearly an amazing surgeon because she can place a catheter into these bladders and tunnel it up to the neck, and it still works 2 weeks later. So she can do urodynamics in these mice. And what you see is that when you have a mouse that's not been operated on, they have a reasonably normal voiding cycle. But if you obstruct them, they have these small frequent voids with high pressures, and that tends to improve when we treat them with DMAG. The problem, well, to summarize, DMAG, which is a HIF blocker, tends to improve but not completely alleviate the effects of bladder outlet obstruction in these mice. The problem with DMAG is it's a chemotherapeutic agent, and so giving it to infants is not an option. But it sort of proved our hypothesis that the HIF pathway may be one of the factors. And so another potential is vitamin E. And this works because it scavenges these reactive oxygen and nitrogen oxide, which helps to stabilize HIF activation, so you get less HIF formed. And there have been a number of studies looking at vitamin E. And the active ingredients of vitamin E are these tocopherols and tocotrienols. And we used tocotrienol in our next study. So we basically did exactly the same thing, except we gave these mice through lavage either a placebo or tocotrienol. And what we found was unfortunately not quite so exciting as using DMAG. What we found was that if you look at the bottom, you'll see that the number of voids definitely goes down. If you look at the black and then the next line over, you'll see that the number of voids goes down and the number of small voids goes down, suggesting that we are improving this just a little bit, and that the EFS stimulation, electrical field stimulation, you do see some minor improvement, but not a huge improvement. We also saw that the collagen tended to improve in our treated group, but not with the same level that we saw with DMAG. And another way to look at this is you can put mice in a chamber and have a little blotting piece underneath, and you can measure their urine spots. And once again, we saw that there was a tendency to reduce the number of voids once we gave the treatment. So this was not as exciting as DMAG, but certainly suggested to us that this was worth further investigating. And then there are other types of tocotrienol that we can look at. The problem is that isolating tocotrienol is quite expensive, so this is potentially a very expensive treatment option, and certainly expensive to study, but so is chronic renal failure. So we think that there is some potential for this in the future, and we're continuing to study this, or we certainly have plans to continue to study this, but at the moment there are really no drugs that are very active against partial bladder obstruction, and I don't think there are any drugs currently being manufactured or worked on to do this, but this is a potential option in the future.